Good morning. I'm presenting behalf of Medicine 1. 35 years old housewife presented with the chief complaints of high grade fever for 20 days, multiple joint pain for 20 days, loss of appetite for 20 days, and loss of weight for 20 days. History of presenting illness. She presented she was apparently doing well before 20 days. Then she developed a high grade fever, documented temperature of 102 to 104 Fahrenheit for the duration of 20 days, which is intermittent, associated with chills, diurnal variation more during night times, and relieved by taking antibiotics. She also complained of a joint pain involving multiple lower joints such as shoulder joint, elbow joint, left hip joint, and lumbosacral joint. More pain felt in the left hip joint compared to other joints. Pain aggravated after working, associated with restriction of movement, and not associated with the morning stiffness. She lost a weight of 6 kgs over 20 days, and she also complained of loss of appetite. No history of headache, abdominal pain, skin rash, nausea, vomiting, diarrhea, burning, micturition, limb deformity, uveitis, conjunctivitis, oral ulcers, subcutaneous nodules, myalgia, chest pain, palpitation, syncope, and breathing difficulty. She is a known case of diabetes mellitus for past 5 years and non-compliant with the medication. She is a known case of bronchial asthma for past 8 months and on inhaler formonide and salbutamol. She consumes mixed diet and she has normal bowel and bladder habits. On examination, she is conscious, oriented, dull looking, and febrile. No pallor, icterus, cyanosis, clubbing, pedal edema, generalized lymphadenopathy. Vitals, pulse rate 98 beats per minute, which is regular. All peripheral pulses palpable. Blood pressure under systolic of 100, diastolic of 60 millimeter of mercury. Recorded in right upper limb in sitting position. Respiratory rate of 14 breaths per minute. Temperature 104 Fahrenheit. Saturation 97% at room air. Systemic examination, cardiovascular system, normal heart sounds, S1 and S2 heard and no murmur. Respiratory system examination, inspection, trachea in midline, palpation, no intercostal tenderness on both the right lung and left lung, and percussion resonant note noted over the all areas of right lung and dull note over the inframammary, infrascapular, infraaxillary and infrascapular areas of left lung, and on auscultation, normal vesicular breath sound heard all over the right lung and decreased breath sound over the inframammary, infraaxillary and infrascapular areas of the left lung. Per abdomen, soft, no organomegaly, but tenderness over the right hypochondrium. Central nervous system, no focal neurological deficit. Musculoskeletal system examination, both shoulder joint inspection, no swelling and no deformity. Palpation, tenderness over the acroclavicular joint of the both shoulder joint, and movement, no restriction of movement of both shoulder joints. Coming to left hip joint examination, inspection, left hip in a fixed and adducted attitude, fixed flexion deformity of 20-degree noted, palpation, tenderness and warmth over the greater trochanter of the left hip joint, and all movements were painful and restricted. Flexion is of 20 to 90 degree, and internal rotation, external rotation, abduction and adduction cannot be elicited due to pain. So here, in this case, the symptom complex considered were high-grade fever with oligoarthritis in uncontrolled diabetes mellitus with a loss of weight and loss of appetite history.
So why are you not bringing in that respiratory system findings here? You had dull notes, diminished breath sounds on the left infrascapular region, right?
Yes.
That also should be included in your syndrome complex, right?
Along with the right hypochondrial pain, tenderness.
So what do you think that was due to? The pulmonary findings? What was your guidance?
Effusion, pleural effusion, left-sided pleural effusion. So for this syndrome complex, the differential considered were any infectious arthritis involving multisystem and the rheumatological diseases, then lymphoma and leukemia. We proceed.
Can you please go back to the one rule of thumb to remember is that polyarthritis is the presentation. This patient did not have polyarthritis, but here you have written polyarthritis. Don't consider infectious arthritis as the most important differential diagnosis. It's a mono or oligoarticular arthritis is infectious arthritis. There are rare exceptions, but then polyarthritis is Not, you should consider other etiology, not infections.
Here, oligoarthritis.
Yeah, correct.
Pleural effusion, abdominal involvement according to your symptomatic. So your diagnosis should be for that. Again, like sir said, polyarthritis, monoarthritis is more like a septic arthritis. Polyarthritis, you should not see that as the first. And here your approach should be like for a multi-system.
Investigations, hemoglobin of 11.2 gram person, total count of 6,500, and a platelet count of 1,13,000, urine routine normal, ESR of 76, and the C-reactive protein of 201, creatinine of 0.72, and the sodium of 136, potassium 3.8, with the deranged liver function test, total bilirubin of 1.73, direct bilirubin of 1.35, total protein of 5.1, albumin of 2.2, AST 83, ALT 59, followed by ALP 397. So we proceeded with the multi-system involvement with the oligoarthritis. First, initially, because of the severe pain complaint over the left hip joint with deformity, we consider it as a septic arthritis as a first DD. But the X-ray of the left hip joint showed no features of sclerosis, no joint space narrowing, and no articular surface destruction. So then we proceeded with the other causes. First, in the setting of uncontrolled diabetes mellitus, we considered meloidosis, then endocarditis, but echocardiogram showed no vegetation. Brucellosis, brucella came negative. Mycobacterial and fungal arthritis, where bone marrow for fungus and mycobacteria became negative. Viral arthritis, bloodborne virus screen became negative. And then we consider post-infectious arthritis conditions like a rheumatic fever, but ASO titer is 194 and DSDNA is 1. And enteric fever, viral test become negative. In a rheumatological illness, we have considered rheumatoid arthritis, but anti-ACC PLISA is 1 and the rheumatoid factor is less than 11.2. And systemic lupus erythematosus, ANA become negative. In the setting of lymphoma and leukemia, we have done a bone marrow biopsy. It showed in the peripheral smear only mildly hypercellular marrow with no abnormal cells. In biopsy, scanty fragmented marrow with non-specific reactive changes. Because of we are clueless at this point, so we have proceeded with the CT thorax with abdomen because of finding of a right hypochondrial tenderness. So here they showed a small patch of dense consolidation in a apico-posterior segment of left upper lobe with areas of breakdown within and the surrounding ground glass opacity. Bilateral minimal pleural effusion with the subpleural patch consolidation atelectatic band, and mild sphenomegaly with a few round scattered and subscapular wedge-shaped non-enhancing areas, possibility of influx or infection, microabscess. So we proceeded with the pleural tapping, where pleural fluid is of a transudate type according to Light's criteria. So finally, after the 10 days of all investigations and continuous high spikes of fever, finally the blood culture has grown Burkholderia pseudomele on 12th January, which is susceptible to septacidin and meropenem. So the initial diagnosis we considered were disseminated meloidosis, which is septicemic form involving left upper lobe consolidation with the bilateral pleural effusion with the splenic abscess. So we have started
arthritis, left hip joint arthritis. Was the imaging done? Was an arthrotomy done?
Sir, coming.
Okay, coming.
So we have started her on injection septacidin 2 gram every 6th hourly and the quatrimoxazole twice a day on 9th January based on the preliminary report. Even after 2 days of antibiotics, the fever spikes did not settle and hip pain persisted. Left hip pain more than the right hip pain. Other joints pain are settled. So we proceeded with the ultrasound of the musculoskeleton of left hip joint, which showed left-sided mild effusion and features of synovitis. So we immediately obtained ortho opinion and posted for emergency left hip orthotomy and debridement on 11th January. After debridement, no fever spikes and the joint aspiration fluid also has grown Burkholderia pseudomele. So the final diagnosis in this case considered were disseminated meloidosis, which is septicemic form involving left upper lobe consolidation with the bilateral pleural effusion with the left hip septic arthritis and splenic abscess. So septic arthritis is considered as a deep-seated collection. So we have planned to give an intensive phase duration of 4 weeks and eradication phase duration of 3 months. So meloidosis is most commonly present as pneumonia, skin infection, genitourinary tract infection, but followed by rarely septic arthritis, followed by neurological involvement, followed by osteomyelitis. In immunocompromised individual with a prolonged fever with multisystem involvement gives suspicion of infective endocarditis, brucellosis, and meloidosis. If there is a high suspicion of meloidosis, we can empirically start an intravenous ceftazidime in order to avoid mortality associated with meloidosis according to the below article. According to
can you please go back to the slide? So you're recommending empiric treatment for meloidosis.
No, sir.
In which patient?
When there is a high suspicion, like in that.
Suspicion based on what? Epidemiology, clinical presentation?
Uncontrolled in setting of immunocompromised states like uncontrolled diabetes.
No, please don't do that. Also, can I ask, this patient's presentation was for fever and hip joint pain, and you had a grossly abnormal left hip physical examination. You said all movements were restricted with severe tenderness. You could not even perform some maneuvers. So why was not orthopedic consulted on day 1 or day 2 or day 3? Why was there such a long delay in consulting orthopedics? You said you started antibiotics, there was no response to fever, then only you called the orthopedic surgeons. Why was there such a long delay? So remember, when somebody with prolonged fever, the first question is that where is the focus? Where is the money? Meaning you should approach that organ system first rather than wait for everything else to occur. Why was not orthopedic consult on initial part of the hospital stay? All
hip joint finding came on 10th started from 10th, sir.
But then you presented it as a presenting symptom. So it was not there at the time of presentation. Is that correct?
Yes, sir.
No, you didn't understand sir's question. You have somebody with a fever with a localizing feature. Where did you localize? You initially said it's multi-system, but in your slide you localized it to which part of the body?
Left hip. Left hip joint.
Yeah, so as a physician, what will you do next? Is the hip joint amenable to an X-ray? It has so much muscle and...
They did a plain X-ray, but no further imaging. At least they didn't present it.
So as a physician, what will you do? What are the tests you will do next and proceed?
Ultrasound.
Ultrasound. You could have done an MRI and just gone ahead straight with a hip joint aspiration, which will have proved your diagnosis. Instead, you're saying this, what you're recommending is murder of meropenem. Just saying anybody just give meropenem. That is not how a physician works. You have to have some kind of thinking process where you tell them how you approach the case. So, and not say empirically, giving a differential diagnosis is extremely varied for somebody with fever with hip joint complications.
Ma'am, at the time of presentation, there is no such a hip findings, ma'am. I wrongly typed everything.
See, when I started, I said it's a clinical meeting, okay? And in clinical medicine, you can stumble onto a diagnosis, or you have an active process of getting a good history, doing a physical examination, formulating a list of differentials, okay? And then approaching the patient so much. So what we would like all of you to learn is the process of clinical reasoning. Okay, rather than, see, we work in a place like CMC, you can do all tests for everybody, meaning practically all tests. I'm not saying all tests. So you presented what all you do? Rheumatoid factors, anti-CCP, ELISA, lot of tests. Meaning, why did you even consider rheumatoid arthritis as a differential diagnosis in this patient? Okay, so please develop your clinical reasoning skills and don't make statements like you will start empiric therapy for meloidosis. Did you find it in any standard textbook? Harrison, did you find? Does Harrison recommend, or Mandel's textbook of infectious disease recommend empiric therapy for meloidosis? Okay. Yeah, go ahead.
According to this study, it conducted in 154 people of culture positive septic arthritis. Among this, 48% were found to be positive for Burkholderia pseudomyelitis, followed by 29% were considered to be positive for Streptococcus species. Among the 74% of Burkholderia pseudomyelitis septic arthritis, 61% are found to be due to the monoarthritis, followed by 13% of polyarthritis. Even the 54% among the 74% received effective antimicrobial therapy. Even after receiving effective antibiotic therapy, the inpatient mortality accounts to 25%, and deformity accounts to 7%, and limited range of motion without deformity accounts to 10%. So in our patient, we have planned to follow up on OPD basis in medicine orthopedic to look for development of any osteomyelitis in future, and to compliance to intravenous medications, and for glycemic control. Because according to the below study, it was found that there was 27.5% risk of osteomyelitis of the adjacent bone in patients with the septic arthritis in the lower limb. So learning points, I always try to eliminate the focus of infection in the setting of persistent symptoms, even after appropriate and adequate dose of antibiotics. Consider meloidosis as one of the differential of septic arthritis in immunocompromised individuals. In meloidosis predominant regions such as Southeast Asia, Northern Australia, South India, and China. Septic arthritis is rare but a well-recognized manifestation of this disease. Daily examination of joint and looking for joint tenderness helpful in early diagnosis of septic arthritis. Thank you.
Thank you, Lakshmi. Questions or comments? Thank you. Okay.